Good evening everyone. Today the topic of presentation is approach to edema. So we know in our day-to-day practice we see a lot of cases of edema presenting into our IP and in outpatient department. In inpatient department most of them are related to cardiac or hepatic causes or renal causes, where you find in a cardiac case you will find shortness of breath, raised JVP, and also hepatic congestion and pedal edema. In the case of hepatic cause you will find splenomegaly, abdominal distension with melena history. And renal causes you always find periorbital puffiness, decreased urine output, and pedal edema. So most of the IP cases can be attributed to this, but there are some cases of edema that presented to OPD. So the main the case based discussion in this topic is mostly about the how patient presenting to OPD should be evaluated, because we already know in IP cases most how to evaluate in IP cases of cardiac and hepatic. So here I am going to discuss about the other cause other than commonly cardiac, renal, and hepatic cause. I'll look into the other causes of edema. So case 1, a 24-year-old female presented to OPD with the complaints of edema of limbs, face and hands, which are especially aggravated during the times of menstruation and continued during and after menstruation for few days. Her 2D echo is normal and serum creatinine is 0.6 milligrams per deciliter and no proteinuria, and serum albumin is 4.1 grams per deciliter. Her TSH is 2.8 milli international units per ml. So you can see this is a 24-year-old female with complaints of edema of limbs, face and hands. So it's almost like generalized thing. And the striking point in this case is there is aggravated during times of menstruation, that there is a periodicity and is you present during the time of menstruation and few days after menstruation also, but there is specific aggravating factor and there is periodicity during that time. On evaluation, her 2D echo, routinely 2D echo is normal, serum creatinine is normal, there is no proteinuria, and also albumin is normal. So hepatic, cardiac and renal causes are ruled. Her thyroid profile is also normal. These four are the common systemic causes of any edema case. So these four are normal. So how do we go about this case? So any case of patient presenting with bilateral edema, first we'll rule out if the patient is elderly, we rule out the cardiac cause. Any 2D echo and ECG should be done. Hepatic cause, where you get a serum albumin, that can be due to liver cause per se, or due to the malabsorption in diarrhea, malabsorption in the intestine also can cause low albumin and low globulin levels. So and also any proteinuria should be suspected. Any proteinuria is also can cause low albumin, and also any proteinuria and raised RFT, raised creatinine, which is causing decreased filtration in the kidney, decreased urine output, can also cause edema. So first cardiac, renal and liver cause should be ruled out. Then hypothyroidism can also cause edema, generalized edema, cold intolerance, constipation, irregular menstrual cycles. That should also be looked for any case of patient presenting with generalized edema. So here these four common causes are normal. So next we think about the other causes, like if the patient is long standing, if this patient is working for a long time, you should always get a Doppler to look for any venous insufficiency, which is not in this case. But one striking point in this case is there is period of aggravation during the time of menstruation and after menstruation, after few days. So there are two variants of edema which are called idiopathic edema and premenstrual edema. So first we will discuss about premenstrual edema. So premenstrual edema is generally seen just few days before, before menstruation. Because of the hormonal changes, there is edema associated with breast tenderness, and also some mood abnormalities are also seen. So this is all combined called premenstrual syndrome. But premenstrual edema can also be a part of it, where it is generally seen before few days before menstruation. But here in this case, it is present after menstruation, during the menstruation also. So this is not a premenstrual edema, where premenstrual is more localized and present few days before menstruation. So that is more of premenstrual edema, where you advise salt restriction and dietary low salt diet, and also limb elevation, and also if there is any breast tenderness or something, you can advise NSAIDs, naproxen or ibuprofen for the pain relief. So here the edema is for longer duration and is also more generalized. So this is looking like more of an idiopathic edema, where idiopathic edema can cause more generalized edema in the limbs, hands or face edema that can be present, that more of periodic thing, and it also is due to the secondary hyperaldosteronism. So in this case, this is more looking like idiopathic edema, whereas there is more generalized edema and it is longer duration, present few days after and during menstruation also, which is unlike a premenstrual edema. So this more can be labeled as an idiopathic edema after ruling all the systemic causes: venous Doppler, cardiac, renal, hepatic, thyroid, any other probable, any DVT, all should be ruled out before labeling it as a idiopathic edema. So what is the treatment for idiopathic edema? Idiopathic edema can be treated with spironolactone. Spironolactone is a drug of choice for idiopathic edema because the basic mechanism is due to the secondary hyperaldosteronism. So this is mostly a case of idiopathic edema. A 50-year-old female, known case of diabetes mellitus, hypertension, diabetes mellitus and hypertension present with complaints of pedal edema. How do you approach this case? This is a straightforward case, walking into the a 50-year-old female walking into the clinic with pedal edema, who is known case of diabetes mellitus and hypertension. First thing, you should always check for the drug history if there is any recent change in the drugs, because there are few antihypertensive like beta blockers and calcium channel they can cause edema per se. So they should any recent change of drug history should be always asked there. And also in diabetes also, because of the autonomic failure also can cause edema, so you should always ask for any postural hypertension. That history also should also ask for orthostatic hypertension, orthostatic tachycardia, and they also should be asked for in this patient. But since there is a pedal edema, always cardiac and renal causes should be ruled out before, because already there is significant diabetes and hypertension history. He is prone to have cardiac or renal illness. So 2D echo and ECG is a must in this patient. Also urine protein creatinine ratio or CU with the renal function test to look for any renal or cardiac abnormality should be looked for. So this might be mostly a case of cardiac or renal cause based on the etiology. If still it is not there, you should look for the hepatic cause, then look for the Doppler if there is any chronic venous insufficiency or anything, or any varicosities or any DVTs. Unlike in a chronic edema, if it is acute, you should always look for DVTs also. So one thing important is hypertension, any new change of drugs, and diabetes. If there is any postural hypertension or the static tachycardia, you should always be looked for any autonomic failure symptoms also. In males, erectile dysfunction can be asked, which is the earliest symptom in the autonomic failure. So this all can be asked in the part of diabetes related autonomic failure. Case 3. A 43-year-old female presented with complaints of generalized anasarca, which is non-pitting. Her TSH is 74 million international units per unit. So how do you approach this case? So it is a straightforward case where patient present with generalized anasarca. If you ask for it, you should get a history of constipation, irregular menstrual cycles, cold intolerance, weight gain. That also should be asked for. So this is mostly looking like a hypothyroidism related edema. So before you can start at 1.6 mics per kg body weight. Around, if patient is around 60 to 65 kg body weight, you can start around 100 mics per day. And the thing is, you should always look for the any cardiac illness or any atrial fit or any atrial fibrillation history, any arrhythmic history should be asked before going for the starting the thyroid. If the patient has cardiac history, you should always start at the lower dose and gradually titrate upwards, because suddenly giving high amount of thyroid can cause atrial fibrillation or any arrhythmia, can trigger an arrhythmia. So if there is significant cardiac history, you should always start at a lower dose and gradually titrate it upwards. So the symptom improvement in this patient takes time. It will take around TSH will normalize around after 6 weeks, and the symptoms will improve 1 month after that. So it might take times. It will take around 2.5 months for the patient's symptoms to feel better. So any hypothyroidism, if you start treatment, you should counsel the patient. It will take time for symptoms and TSH to normalize. At least 6 weeks to 2 months it will take for the TSH to normalize, and symptoms to it will take a few more weeks for the symptoms to normalize. Case 4. A 23-year-old female complains of unilateral edema started 3 days ago after she took long flight journey. How do you approach this case? So as you can see in the history, it is a 3-day edema after long flight journey. So any acute edema should always suspect a case of, you should always raise a suspicion of deep venous thrombosis. So any patient, especially bedridden or after surgery or any long flight, or patient who are sitting in, who are in a position for a long time, like especially stroke patient or critically ill patient who are there in the bed for the long time. So in them, the patient suddenly present edema, you should always rule out DVT. So in this patient, you should get a Doppler done, look for any DVT. If the patient has DVT, you should start with an enoxaparin or heparin straight away, and it could be continued if it could at least for 3 to 6 months until the edema resolves. Since if there is a trigger, if the patient doesn't have any obvious trigger, you can at least continue for 2 years. If there is a trigger like any trauma or critical illness, or if there is any specific trigger, you can continue for 3 to 6 months. If there is no obvious cause for the DVT, you can at least continue for 2 years also, sometimes 6 months to 2 years based on his risk and all. Case 5. A 52-year-old doctor who works in a clinic in Hyderabad complained of edema, and on examination there is pigmentation around gatus area. How do you approach this case? So here you can straight away go ahead, because there is a pigmentation in gatus area, you can straight away say it's a case of venous insufficiency, so which is common in surgeons and policemen who stand for long periods of times. So it is a case of venous insufficiency, probably due to the varicosities. So on examination on limb, you might find dilated varicose veins on the limbs. You get an ultrasound Doppler, you will find varicosities. You can put up a CEAP classification. So how do you approach this case? This is a case of chronic venous insufficiency secondary to varicose veins. So you advise him to limb elevation and also compressive stockings. Like you can advise class 1 or class 2 compressive stockings in these patients, because so when do you advise a compressive stockings in a patient with varicose veins? Any for normal mild varicose veins also you can advise compressive stockings. But when patient has edema, some pigmentation, some lipodermatosclerosis, some ulcer, or if the patient has chronic heart failure which is having congestion symptoms related, all of those patients, any of the patient who are symptomatic, the compressive stockings will help. So the different class of compressive stocking, class 1, class 2, class 3, based on the severity of varicose veins, you can advise. You can start with class 1 based on the severity. In class 2 or class 3 can be used. So there are different kinds of compressive stockings where you can use above ankle, below knee, above knee, above thigh. So higher, obvious, the efficacy is better. Based on his patient comfort, you can advise the compressive stockings. Case 6, a 64-year-old male recently diagnosed with hypertension was put on amlodipine and metoprolol, now present with complaints of pedal edema. How do you approach this case? So this 64-year-old male recently diagnosed with hypertension, started on some drugs of amlodipine and metoprolol. So then he presented with edema. So this is looking like more like a drug-related edema. So what we generally miss is a patient who is recently started on some drugs, especially non-steroidal NSAIDs and beta blockers, calcium channel blockers, or some hormonal treatment like testosterone, estrogen, or steroids. The patients immediately after a week or two he presents with edema. First, you should always suspect drug-related edema. So maybe you can stop the drug, the edema will resolve. So this is clearly looking like drug-related edema. The common causes we see in a drug-related edema in our setup is, one is estrogen, progesterone, testosterone, the sex-related steroids, and also a non-steroidal anti-inflammatory NSAIDs commonly cause edema, and calcium channel blockers and beta blockers. These 4 drugs you should always keep in mind when the patient presents to edema after starting those drugs. So a 24-year-old female presented to OPD with the complaints of inhalated edema of left leg, and an evaluation, cardiac, renal and liver parameters are normal, thyroid function is normal, Doppler ultrasound showed no varicose and no venous insufficiency, and subcutaneous edema is present. How do you approach this case? So this is the case I have seen in my OP in my residency. So 24-year-old female presented with unilateral left limb edema, no periodicity or no menstrual related changes, cardiac, renal, liver function are all normal, thyroid is also normal, Doppler showed no varicose, no DVT, anything. So then we thought of what could be the possibility of unilateral left limb edema. So then we got a venous venogram done, where we found May-Turner syndrome, where there is a compression of left iliac vein by the artery. This is a rare case of May-Turner syndrome, which commonly present in the left side of the limb, left line edema. This is a case of May-Turner syndrome. So case 8, a 38-year-old male presented with history of trauma to his left leg 2 months ago, presented to OPD with the complaints of pain and swelling of the left leg associated with redness. How do you approach this case? So this 38-year-old male, history of trauma is present. He now present with pain and swelling associated with redness of the leg. So what is the possibilities? One, you can always suspect cellulitis because of the pain, redness and swelling of the limb. The other thing is, because there is a trauma, if the patient has pain, severe pain associated with redness and sweating, you should always suspect reflex sympathetic dystrophy also. So this might be a case of cellulitis or reflex sympathetic dystrophy based on the symptomatology. If the cellulitis is there, you can treat with antibiotics and also max sulfate dressing. And if it is a reflex sympathetic dystrophy, you can try pain management with NSAIDs and opioids and pregabalin, gabapentin. You can also start lignocaine, and you can use nerve blocks also if it is a reflex sympathetic dystrophy. So you should always keep the mind, history is always important when you are diagnosing a case. So this is the last case. So I'll brief about all the possibilities. First, if any patient present with bilateral pedal edema, you should always look for the systemic cause like cardiac, renal, hepatic cause, then hypothyroidism. You should always get a Doppler done for the lower limbs to look any for venous insufficiency, especially if there is a patient like any long-standing person like surgeon or any policeman. You should get a Doppler done, you should look for any varicosities. If the patient doesn't have that, then you should always ask if there is a female, you should always, especially young females have idiopathic and premenstrual edema, around 20 to 40. So in them, you should always any menstrual related changes in the edema. Then if it is a premenstrual edema, if it is presenting, periodicity is present but it is prolonged a long time, idiopathic edema, which is also commonly seen in young females. Then if it is idiopathic, you can always tell a spironolactone. And there are also causing elderly females, you can find dependent edema because of the with the aging, you can find dependent edema also. So sometimes drug related edema should always keep in mind if the patient is recently started on some drugs. So then if there is also pulmonary artery hypertension, patient who is obese and has OSC, obstructive sleep apnea, component, the patient may have pulmonary hypertension, right heart failure can cause pedal edema also. And also sometimes just because of generalized obesity, there is lipid deposition, there is a fat deposition in the subcutaneous tissue, that is called lipedema. So lipedema is also, it is just fat. So you need to just counsel that lifestyle changes and dietary changes and weight reduction to those patients. So these are all the causes you should look for in the case of bilateral lower limb swelling. In any patient with unilateral lower swelling which is acute onset, you should always rule out DVT. If it is chronic, again you get a Doppler done, any venous insufficiency, always systemic cause should be ruled out. And other causes like after these causes are also negative, you should always look for lymphatic causes also. So if there is any lymphatic infection related or infiltration related, any cancer causing lymphatic infiltration, causing compression of lymphatics, or any irradiation exposure to the lymphatic drainage, that can also cause edema unilaterally or bilaterally. There is congenital cause of lymphedema also. That should always be thought also after, if you rule out all these causes. Unlikely, but there are also possibility. So these are all causes should be evaluated. So here I am making the list of the things which are the common causes you see in the edema. Drugs, mainly antihypertensives, calcium channel blockers, beta blockers, and hydralazine, clonidine, which we don't see in the day-to-day practice. Hormones, any sex hormones, sex steroidal hormones can cause. NSAIDs should always keep NSAIDs, and also pioglitazones should be kept in mind, like pioglitazone and rosiglitazone and MAO inhibitors also can cause. So Harrison's also mentioned the similar list, but the other drugs like cyclosporin, growth hormones, and also immunotherapy should also kept in mind, where they can cause drug-associated edema formation. So first main drugs, NSAIDs, beta blockers, calcium channel blockers, and any sex steroidal hormones. Steroidal hormones like glucocorticoids also can cause. So what are the common causes of leg edema? Most commonly, if it is acute onset, unilaterally, always DVT should be suspected. Chronic venous insufficiency. Bilateral venous insufficiency, pulmonary hypertension, that can be due to OSC or chronic lung disease or right heart failure, anything. And heart failure, idiopathic edema, lymphedema we discussed. That can be, lymphedema can be primarily due to the congenital causes, secondary due to some infection like filariasis or some bacterial infection or malignancy, lymph node infiltration or radiation exposure, trauma related, anything. Drugs I already mentioned, premenstrual edema and excess, pregnancy due to IVC compression, obesity due to generalized fat deposition also can cause edema. Other less common causes like any orthopedic causes like compartment syndrome, Baker's cyst, are unlikely to be seen in our OPD. And chronic cause like any secondary lymphedema, like any tumor infiltration, reflex lymphatic dystrophy, I already discussed one case. And also bilateral DVT also should be, acute DVT should be any acute worsening of heart failure. Other renal, liver, secondary lymphedema, dependent edema, any preeclampsia, lipedema, anemia related heart failure can also cause edema. Other rare causes like primary lymphedema, especially around younger ages can cause primary lymphedema, can be congenital lymphedema, lymphedema precox or lymphedema tarda. And congenital venous malformations can also cause edema, unilateral edema, or May-Turner syndrome is also a possibility. So bilateral, you can look for chronic causes like primary lymphedema, protein losing enteropathy, already heart causes, beriberi disease, B1 deficiency can also cause edema. So other rare causes of leg edema I already mentioned. Then how do you test a idiopathic edema? So this like morning after waking up, you should ask them to weigh the patient, and at bedtime you again weigh the patient. If the weight gain is more than 0.7 kgs, it is consistent with idiopathic edema. This is one of the tests you can use, but is unlikely, but just for your knowledge I am mentioning. Morning and at bedtime, there is a weight gain of more than 0.7 kg, suggestive of idiopathic edema. And lymphedema, we discussed primary lymphedema can be congenital lymphedema, lymphedema precox, or lymphedema tarda. I am not going to discuss much about it. Congenital lymphedema is presenting less than 2 years generally, and it is also called Milroy's disease. Lymphedema precox generally present in 2 to 35 years. It is also called Meek's disease. And lymphedema tarda is generally present about 35 years of age. So these are the classification of compressive stockings we use. Generally, class 1 or class 2 generally use. Class 1 is 15 to 20 millimeters of mercury, and class 2 is 20 to 30 millimeters of mercury. Generally, class 1 varicose veins, mild edema, and DVT prevention. So always remember this in our day-to-day in-hospital care. You should always advise DVT stockings to the critically ill patients, stroke patients who are immobile, and they are on the bedridden for a long time. You should always DVT prophylaxis, either with heparin or compressive stocking, should always keep the patient on the prophylaxis, because to prevent the risk of DVT that internally can lead to PTE. So always DVT prophylaxis should be advised in the patient chronically bedridden patients. So if the moderate varicose veins or mild edema is present, or venous ulcer is there, recurrence is there, class 2 can be. If there is severe or treatment of venous ulcer, you can always advise the class 3 venous stockings. So that is it. I hope you learned something from this discussion. Thank you.